Today, I'm excited to be joined by Dr. Julie Ries, an expert in dementia care. We'll take a closer look at the important topic, explore recent research, and share practical takeaways you can start using right away. Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Welcome, Julie.
Hi, JJ. I'm really so excited to be here today.
I'm excited too. I would love for you to get us started off by sharing a bit about yourself and what drew you to working with people living with dementia.
Well, I'm a physical therapist with a few decades of experience now, and I teach at Marymount University, which is in Arlington, Virginia. And I've had a special interest in older adults and neurologic rehab throughout the course of my career. But when I was completing my PhD and trying to figure out a focus for my dissertation, I got some excellent advice from a mentor who said, "You should study dementia. No one is really studying dementia, and we need that within our profession." So my dissertation was looking at a methodological study on outcome measures and whether we could use them reliably with people who had mild to moderate dementia. And subsequent research has really focused on balance training in dementia and this framework that we're going to talk about today. I really feel as though within all of the rehab professions, we could do a better job of working with these patients who have cognitive impairment. And so that's my mission, is to help really educate others who are in rehab medicine and allied health professions to really help them get the most of their patients who have cognitive impairment.
I want to shout out to whoever gave you that advice because it's such a challenging area, and I think that's very frustrating for people. For therapists, we want to do the best we can for our patients. So why do you think it's important for the whole rehab team, right? I mean, physical, occupational, speech therapists to reflect on how we approach working with them. People living with dementia makes us nervous and I think that then we're hesitant. So what kind of assumptions or habits do you think might be shaping our care without us even realizing it?
Yeah, I think what happens is we immediately, when we hear dementia, we immediately default to worst case scenario or just a palliative level of care for people with dementia. Or we think back to an unsuccessful interaction with someone with dementia, because those tend to stick in our minds. And, I worked for many years once I started teaching in PRN in a large hospital in my area. And the rehab team would leave little love notes for one another, the PTs, the OTs, the SLPs, about different patients. And I remember on more than one occasion getting a love note about a particular patient, and it would say, this patient was admitted with pneumonia, has moderate to severe Alzheimer's disease, was functioning well at home with support of husband, but not following commands, not able to participate, low priority. That was what the love note would say, low priority. So when you go in, and I was working on the weekend, and I see low priority for this patient, and in my brain, I'm thinking, this is the highest priority patient because they were functioning well before this hospitalization. And all we need to do is get them back to that baseline, and maybe we buy them more time living independently with their family. So there really was this bias, I think, that became very clear to me and my colleagues. Um, And in the literature, you see a lot about what they call therapeutic nihilism. It just makes me feel smart to say that out
I
loud.
was
But
going to
what
say,
it
wait,
means,
what was that word again?
therapeutic nihilism, it really means that belief going in that this is not going to be successful.
Mm.
So, you can imagine how that would become such a self-fulfilling prophecy. If a therapist walks in thinking, oh, this is not going to be a good use of my time. I have so many other patients to see. And this patient with dementia is not going to be able to benefit from my services, then it's really unlikely that you're going to have a successful intervention. So I think that concept of therapeutic nihilism, the biases that we bring with us, if we don't know a lot about managing dementia, patients with dementia, these things are just really working against us and creating kind of this fatalistic view for therapists. And so I want to try to change that. I want us to think about, what can I do differently? So if I'm the therapist and I'm not being successful, is it me? And I want therapists to think it's probably me. What can I do differently? So that was kind of my motivation. That was a long answer to my motivation for putting together this framework.
You said so many great things. First, I just loved the love note thing. I just thought that was super cute. But, that whole aspect of high priority and going back to quality of life and trying to get them back to that. And I think that from a therapist perspective, we're so hard on ourselves and we want to do the right thing. And if we don't feel like we have the answer of how to approach someone, if, are we going to get the right outcome? And do we know how to approach them? And I don't know how they're going to respond. And like you said, experience from before, we're just really hard on ourselves. And then we feel bad. And then it's like, I don't know what to do. And so then you don't think there's an answer. So I think, so I wanted to give the audience a little 2 cents about how I came upon your name, because I was helping with the aging adult class for where I teach. And, I like specific strategies. And one of the faculty members I work with brought in your article with this theoretical framework, and it was, I love a visual with the 4 components, and she had this, idea of having the students take a component and utilize it in this scenario, and you guys take this one and use the specific strategies in your 4 components to be able to feel more confident in interacting with a person with dementia. And then if they didn't respond, then you have another strategy. And if they didn't respond, and I just was like so taken away. I was like, oh my gosh, this is like so awesome. I wish I would have had this. And so I was just really excited. And then I was like, I want this person on the podcast. And that's how I was like, and then I saw your name and then I looked you up, and then I just thought that was so great. So I would be so grateful if you could share that framework of that article and
Sure.
kind of go through, I don't know, how you came about it and how you utilize it, or what you were thinking as you developed it, because it was obviously for the clinician and the heart to help us when we're working with our people.
Yeah, I'd love to. And I get so jazzed when I hear, when you say that an instructor is using it in the course. That just floats my boat. I'm so excited to hear that. But this was kind of there was a period of time where I was just kind of making mental note of, how do I interact with patients? How do I get the most from patients? In doing my dissertation research, I was pretty much on my own, and I worked with 53 participants in that study who had dementia. And so you can imagine they had all different levels of dementia. So I really was taking note of, how do I modify my behavior to get the most from each of these different participants. So I'd been kind of monitoring my own behavior, and then looking in the literature, there's not a lot of guidance. So I put together this very theoretical framework. And so I provide evidence for components of it, because there is some evidence that supports certain components. But I put this out there for people to use and comment on and provide feedback on, knowing very well it's not truly grounded in solid evidence throughout. So that's kind of my disclaimer up front. But
Well, and I just
Um,
want to emphasize that, this is how it gets started, because right now you're right. The literature, when it comes to how do we help and communicate with this population, is just so, so limited. So I'm just so grateful you took what you could and what was out there to develop this. And I agree that, I would just encourage y'all, because I found it very helpful to try it out and then it sounds like you're open to tell me what you think and what did you find?
Absolutely.
Okay. I just wanted to say that because I'm excited about it.
So it's as you mentioned, there are 4 areas of focus, and the first one that I think is really important is entitled relationship building. And I think, PTs and OTs and speech pathologists, anyone in the rehab world, really is generally pretty good at establishing rapport. And we do that with all of our patients. This is not unique to patients with dementia. But what is unique is that individuals with dementia can't really necessarily rationalize this person coming into my room right now, or this person who I've gone to see for outpatient therapy, has my best interest in mind, is going to tell me things that are going to help me get better. So I'm going to follow their advice. They don't necessarily have the ability to rationally think through things as your patients in the orthopedic outpatient clinic do, or your cognitively intact patients in the acute care environment. So, with this population, knowing who they are, knowing what is important to them really helps to build relationship. So, if I meet a new patient in the inpatient environment and I see who their family support is, then I can literally use the name of somebody. I can, literally say, um, you know, to the patient, "Oh, your husband Henry is going to be so pleased when I let him know what we've done today and getting you out of this bed and walking again." And even if this patient doesn't know who I am, may not be clear that they are in the hospital, they recognize Henry. And so they will be pleased to know that I know Henry. And if I know Henry and I'm helping this person with dementia, maybe that helps them be more comfortable with me in the room. So just utilizing names of a spouse or names of pets or names of people that are important to the person I'm with, that can be really helpful in establishing relationship. Reminiscence is a theoretical framework that we use in dementia, all kinds of dementia interactions, where we go into the past with someone. And so if we know somebody was a teacher for 30 years, then we can talk about teaching. And we can do it at all different levels. We can do it at a level where somebody can really tell us about their experience. If somebody's kind of with mild dementia, we can say, "I heard you were a teacher for 30 years. Tell me about it. What was your favorite part?" Or if somebody's more progressed in their dementia, then maybe it's more yes, no types of questions about teaching. "You must have loved teaching. Um, did you like the younger children or did you like the older children?" So talking about something that kind of frames the question a little bit more focused, or when somebody can handle it, that broadens it for a more narrative answer. So just ways to kind of connect. Um,
I really liked how you brought that sentence in with Henry,
mhm,
starting with how excited your husband Henry, so you're reinforcing some information, but again, the reminiscence, giving comfort. I like
mhm.
that, leading with it. It's like we know that, but you're right. I know that, but when you just said that, I was like, I'm not sure I've ever just initiated with that. So that was super cool.
Yeah, yeah. One of the other things that I think is so important, and this is sometimes people think this is a little controversial, but in my mind, I love going into a person's reality. I will never argue with a person about what's reality, and so I make it a habit to really respect the reality of a person who has dementia. If they believe they're living in the past, if they believe I'm somebody that I'm not, I try to never dispute people, and just go with it. And I think it's somewhat of a privilege to go into this world, um, uh, because I feel like I've been invited in. So I'm a guest and I need to behave appropriately, and cordially like a guest.
I love
And I
that.
Yeah, I
tap
think
into their reality because you really are. And looking
yeah.
at it as a privilege, oh, that's great. I love
But I think that's really I think we gain a lot of connection when we do that versus challenging somebody's reality, which a lot of times, not only do professionals do it, but families do it.
that.
Families want to continue to reorient and bring to the present and bring to the here and now and the reality as we understand it. And that's I've actually never found that fruitful. So I think part of this framework is to respect the reality of the person that you're working with, and ultimately just be bringing positive energy. So doing the best we can to have the relationship we're creating be a positive experience for the person we're creating that relationship with. So these are kind of the summary of the relationship building parts of the framework.
I love it. Okay, I absolutely love that one. And the positive energy piece. And then again, just I understand the person's reality and how hard that is for family members and how this is different than if we're working with someone, for instance, who has a traumatic brain injury where we're trying to rewire and reorient. We have to understand the diagnosis and we have to understand what the brain is going through to recognize that this is very appropriate to help, again, comfort them. I like that whole comfort word when you
Yeah,
that.
and that's a really relevant point that the management of this type of cognitive impairment might be very different from cognitive impairment as the result of traumatic brain injury. Um, and I think there are lots of options how to react to a patient. If you have I've done a lot of work in adult day programs, and maybe I have someone there who's saying, "When is Charlie coming to pick me up? When will my husband be here?" And Charlie has passed away, and the person has forgotten that, and they now live with their daughter. And so we have lots of different options when we respond to that. We could be honest and say, "Oh, remember, Charlie passed away," and that might bring a whole cycle of grief that they need to relive. Um, we could try to divert their attention and say, "Oh, we're going to do exercise now. Charlie's not coming until later." So we're kind of diverting their attention and then sort of lying, right? We're lying. We're saying Charlie's coming because we don't want them to be distraught. Or we can maybe respond to what we think might be the motivating emotion behind it. Maybe we don't speak to Charlie at all. Maybe we say, are you feeling confused right now, or are you feeling lonely right now? Come with me. Let's sit over here and talk about that. So really, we can respond honestly, we can lie, or we can respond to what we think might be motivating the statement that the person is giving. And sometimes when somebody is asking for somebody who's gone, maybe they're feeling lonely, or they're feeling as though they should be doing something that they're not doing. So again, what's the best answer? Maybe it depends.
Right.
Depends. But we have options.
That's what I like. That's why I love this framework because, again, then it also, so I know you're going to go into the second, another component because these don't build on each other, right? These are just all equal. Is that how that's set up?
I would say so. The next component is really communication. And obviously, communication and establishing that relationship are really integrated, right? So hopefully, these two kind of components help each other. So with communication, I kind of think about the rules of engagement. How are we best going to interact with somebody who has dementia? And of course, it depends on their level of dementia, right? So some basic rules that I try to default to are to be mindful of how I'm using verbal interactions. So try to keep things shorter and more simple than I might otherwise do. Yes, no options are a great place to start. Using a really confident and direct tone when I speak to somebody. I went through a period of time where I would work with students, and when they would talk, their intonation would go up, and they'd say, "Okay, the next thing that we're going to do is we're going to take a walk and we're going to head down the hallway." And I had to really talk to these students about their intonation because when your voice goes up like that at the end of every sentence you say, it sounds like a question. And
Right.
so to somebody with dementia, they might feel like they're being peppered with questions just based on intonation. And so, this idea of my verbal interaction, I have to be mindful of what I say, but also mindful of how I'm saying it. And so, that's why my tone should be pretty direct and confident, um, rather than that sing song or the change in intonation, because that might it might be interpreted as a question or as something rather than just a direct instruction or a direct statement.
I think
Um,
that's really, I mean, it's so hard. I'll speak for myself. It is hard for me to recognize and use yes, no questions, like
eh,
to keep it simple, to not try to joke around just because of my tendency, and then you read the room like they don't get that, like it's not working. Same with even people with traumatic brain injury. Like I have to
right.
adjust my typical approach. And I think that, but you're right, the tone, how people say they don't remember what you said, but they remember how you made them feel. It's kind of like that, right?
Exactly. Yeah. Although I do want to say, and I'm so glad you brought that up, that I love to joke around too, and I do want to say that a sense of humor is not necessarily lost on somebody with dementia. And as a matter of fact, maintaining your sense of humor and inviting someone into that levity with you is a really positive part of an interaction with somebody. And so, don't yes, no questions are important, but don't stop joking around, because you'll create a tone that's
Yeah.
really helpful.
You're
Um,
right, because I think that's where the positive energy, right?
yeah, yeah.
So yeah, okay, I got you.
One of the other things about tone that I'll say, and this is true across allied health professionals in general and nursing, I mean, this is important for all of us that interact with patients with dementia, is there's this phenomenon that you might hear referred to as elder speak or infantilizing when you interact. And so that can be that real sing-songy, okay, sweetie, we're going to get you out of bed now. And that is really not the best way to interact with someone with dementia. And there's been some research that is surveying individuals with dementia and their families about their perspective on that type of interaction with healthcare providers, and they don't like it. So it's not, just that it takes somebody and it makes them feel like an infant or a toddler. Not it's not just our perception of that, but we have some data that demonstrates, yeah, it really does do that to someone. So trying to avoid elder speak is really an important thing to keep in the back of your mind, especially if that's a default. For some people, that is a default, which is with older adults in general, really. And then I'll say the final thing in communication is really just smile and have a relaxed body language. And I think, you know, COVID was so hard on our ability to interact with people with dementia. I mean, it was hard on everybody. Let's not, who are we kidding? But the blocking of the face, the blocking of the smile, um, that was torture for trying to develop a relationship and interact with somebody who does not have the ability to really read the other components of your verbal expression or your body language. So I can't emphasize it enough. There's a publication called Dottie's 10 Tips for Interacting with People with Dementia. It was published initially in the Alzheimer's Reading Room, which was a website that you could go to for tips and tricks. And it was written by a woman, Dottie, who had Alzheimer's disease. And in her 10 tips, she must have said smile 6 times. It was just such an important component of creating a connection.
And I think, I absolutely love that. And I think that, I think of students first, but because they're in their head and they're thinking, when I see that, they're thinking, what am I supposed to do? And well, how am I supposed to approach them? And why aren't they doing that? And now what am I supposed to do? And so, and then it's just like, well, just smile. Like, I can't tell what you're thinking. I can tell
Yeah.
that you're a thinker, but your patient's going to look at you in general. And so just smile and return. And I just remember a student came back to me and they were talking and they looked so happy. I was like, you look so happy. And she's like, no, you just told me to smile. I was like, oh my gosh, that totally worked. But I just so important.
We need to spread that more broadly.
So I just love that. And because I think when we get caught in our head and we're worried that we're not doing the right thing again, that we start being hard on ourselves. So if we can be nicer to ourselves and smile more, looks like we could get a lot done, right, Julie?
Right. One other thing that I think is super important about communication, as we're working with patients who have dementia, we have to be more directed in our communication, but they're having trouble expressing themselves to us as well. So we have to be more receptive and observant when the patient is trying to tell us something, and they may not have the verbal ability to tell us something. And so one of the other things that's really important in working with people with dementia is really to recognize that their behavior is a mode of communication. So when someone you're working with does something that just seems wacky, rather than judge it for face value, really think about what could have motivated this behavior, right? And then when you think about what could have motivated this behavior, you begin to be able to make sense of the behavior. So here's an example is a patient who just starts stripping down in the general gym area, just taking their clothing off in a general public area for rehab, which seems wacky. But when you evaluate what could be causing this behavior, well, she's hot. She's hot. She's removing layers of clothing because she's hot. She doesn't have maybe the cognitive wherewithal to evaluate, oh, this isn't a really appropriate place for me to do this. But her behavior is actually really appropriate to the experience that she's having, right? Or when somebody becomes really crotchety, you know, and that happens, right? And so if somebody's becoming really crotchety, rather than interpret that as difficult behavior, thinking about, are they feeling confused and therefore frightened, and they're kind of lashing out because they don't know what to do, they're frightened, and could I manage that fear? Could I speak to, do you feel safe? Are you feeling, we have you, kind of thing, expressing that that kind of message to somebody. You're good, you're okay, you're safe here, we've got you. Maybe that will minimize a sense of fear or help somebody be able to work through their confusion with a little less lashing out. And so really trying to think about how to respond to somebody's, what can be perceived as pretty inappropriate behavior. When you really analyze the motivation, then you can see, oh, it wasn't so inappropriate after all. That was pretty appropriate.
Well, I was just thinking when I get crotchety, when I travel, I need to use the restroom immediately, or I'm hungry, or, so I could see it even being basic needs
Yeah,
that may be what
absolutely.
they are looking for and we could offer up.
I'm so glad you said that, JJ, because that is one of the things that we think about, right? When I go to work with somebody, I'm going to get the most out of them if they've been recently toileted, they're hydrated, they're not hungry, and they're not frightened, or they feel comfortable in this environment, right? So we recognized, as you just did, these behaviors in ourselves when we don't have all of our basic needs met.
Absolutely. Okay, so we have relationship building, we have the communication, again, yes, no, short and simple, confident, and smile. And then your third one?
So the third area is really having an awareness of your environment. And sometimes, admittedly, this is a hard one to control, right? If you're in the acute care environment, you have a hospital room you're working in, and you have to work around what you've got. But thinking about what we can do to kind of modify the environment for the best response from our patients. So, I think what happens a lot of times when we think about environment is everyone defaults to physical safety. Like, do people feel physically safe? Is this environment safe from the perspective of I've removed the fall hazards and I have, put things within reach for this patient that they need? So they think about physical components of safety. But in this population, I think physical security is absolutely important, but a sense of emotional security is also really important. And I think if we just become a little more mindful about that, that's a great step in the right direction, right? To think about what would make this person feel calm. What would make this person feel comfortable? And so there are certain things that tend to do that. Even though our patients with dementia, they don't have a great memory. And so they don't remember who you are or why you're there, or, they don't remember things day to day necessarily. However, they do respond well to consistency and familiarity. And these things, this idea of creating a routine for somebody when you're able to do that, really are a sense of calm for somebody. And so I don't think I can overemphasize the importance of trying to do things in a consistent place, at a consistent time, with a consistent person. And then you establish kind of that familiarity of routine. It's not always possible in our crazy rehab world, right? I mean, sometimes we're just doing the best we can to meet the needs of the people on our schedules. But if you are in an environment, as I said, I've worked a fair amount in adult day health centers. It's a perfect center for me to establish routine. I come in and I run my balance class on these days at these times with these student workers helping me. And so it becomes when I walk in, they may not have any idea why I'm there and who these people are, but they wave and they're happy because they know it's been this positive experience. So those things are really important. Creating an environment with minimal distractions is important. And sometimes, like in a hospital environment, maybe that means the best I can do is just close the door or turn the television off. Like maybe that's the best I can do in an environment I have. But maybe I can do even more. Maybe I can use the environment to create different cues. And this is where our OT colleagues are so skilled at this, really evaluating an environment and helping to figure out what are the best cues. What kind of pictures would be appropriate. I think a picture of a toilet on a bathroom door is like magical for some people. And so just thinking about what kind of environmental cues might be helpful. Sometimes there's a big visual perceptual component to dementia, and sometimes a change of tile on a floor uh, is perceived like a cliff for someone, and they don't want to cross it, they don't want to go near it. So there's so many intricacies to the environment, way more than I can talk about. And I'm not expert in this area, but I think it's such an important component to just be aware of as a practicing clinician. And
Well, I was just thinking it's, when you're trying to put yourself in their shoes or try to imagine, like to us, you forget that's the bathroom. But to put a picture there, just simple things like that could make a big difference, especially if you've already observed them and you've already paid attention to their tendencies. And so you're wondering why, you're being curious about why are they acting like that,
right.
and you try different things. And then it's like, once you find something, tell everybody, right?
Yeah, right, right. I mean, that's what we need to do is just share the findings, right? So that we can tell everybody what are we doing and what's working and try this, try that. The other part of the environment that I think about often, and I'm a big proponent of integrating music, and because I think that's part of the joy of
Yes,
being together. But
agreed.
what's really funny is I've been doing this work for 20 years or so with a focus in dementia, and I remember when I started out. and I would pull in music, and it would be big band and Frank Sinatra, and I would carefully pick what I thought was going to speak to this population. But JJ, guess what? Guess what the music is now? It's
Oh
like
no.
the Rolling Stones.
Yes.
It's
Who?
it's Bruce Springsteen. I mean, it's like this is the population. As we have aged, there's been a shift in the music preference. Once in a while, I can still pull out big band and Louis Armstrong and have a good time with it with a group. But more and more, the request is for performers that are feeling a little close to my generation.
That's yes, that's so true. Now you have one more, right?
Yeah, so the final category, and I feel like this is one um, where PTs and OTs, we really have the potential to be so expert at this and to really help others understand about how to best utilize motor learning strengths for this population. So, we are constantly thinking about how to, in the rehab world, how to help individuals um, learn new motor skills or alter their motor behaviors. And there are lots of different things to think about when you think about motor learning. And I think rather than just acknowledging that somebody who has dementia has lost the ability to learn new skills, that tends to be a default for a lot of clinicians. Rather than assuming they've lost the ability to learn new skills, we have to think about motor learning and really gear the way we carry out a therapy session with somebody toward their strengths in motor learning. So there are a couple of things to really keep in mind. One of them is procedural learning or learning by doing is really our goal with somebody who has dementia, right? So for a cognitively intact learner, if we're trying to teach a new motor skill, we use procedural learning. We use practice of the activity learning by doing, but we also integrate a cognitive component, right? We think about a learner's ability to effectively use trial and error, or a learner's ability to self-reflect and evaluate on what went well and what didn't go well, and to make changes based on that. So that those cognitive components, or those things that are a little bit more explicit in our motor learning, are are usually not available to our patients with dementia. If somebody has very mild dementia, they may be able to reflect on what they thought went well with their performance. But generally speaking, um, we, in working with individuals with dementia, we want to really capitalize on learning by doing. And we all know in motor learning that when you want to learn a new skill, it's got to be salient. We want to make it functional. And so when we think about trying to relearn a skill for somebody or teach a new skill to somebody, we have to really live that. We have to really think about, how do I make this functional? Or if I'm rehabbing somebody who has dementia and they've lost some upper extremity range of motion, and we want to functionally or strength, and we want to functionally have them regain those things, then we can push them to the limit by having them do reaching activities that are functional. I want you to take this from me and put it up on that shelf, and have them reaching to do things, and rather than lifting a weight and doing repetitions, you're putting cans on the shelf. Rather than uh, uh, doing something that is just an exercise for knee extension and strengthening the quads, put it in the context of sit to stand. Like, we know that by now. All of our clinicians who work with older adults tend to default to function anyway, right? But it's even more important with this population who we can't reason with. We can't say, this is why I want you to do this. This is going to help you get better. Trust me on this. They can't rationalize it. So a lot of the research in motor learning in older adults with dementia is really ADL focused research carried out by some of our OT colleagues. The other thing is when we think about how we provide practice sessions, when I want somebody who I'm working with who's cognitively intact to master or relearn a motor skill, I generally am trying to create a really broad motor program. I want them to be able to go out in the world and do this skill, right? So I always say, the classic example, sit to stand. If I'm trying to have somebody relearn sit to stand, I want them to sit to stand from every possible surface I have, right? High and low, soft and hard, rolling and stable, right? Because then when they go out into the world and they have to sit to stand to something or from something they've never done it from or to before, they have a broad motor program and they can adapt. This doesn't work that well for our patients with dementia. With our patients with dementia, I want to be really specific. So I want to know, well, what do you need to sit to stand from at home? And I want to gear my training much more specifically toward what their needs are. And the training will be repetitive. It'll be constant versus variable, right? So rather than sit to stand from everything, I'm going to sit to stand from this type of surface that I need to learn for home. And it'll be blocked versus random. It'll be, we're going to do all the sit to stand together. And then we'll go on to the walking. So I just, I formulate the treatment session a little differently than I would with somebody who's cognitively intact. And that way I'm trying to play to the strengths of this person with dementia, give them all they can handle and hope that that's going to be helpful in having them regain this skill. Um, One of the other things that's really relevant for this population, and a lot of therapists maybe haven't heard of this because it's kind of, it doesn't have a widespread um, use in motor learning. And this is the idea of errorless learning, right? So when people are intact in their cognition, they really are able to learn well from their errors, right? We make a mistake, we learn from it, we modify, and then we are better at whatever we were doing. And it's inherent when your cognition is intact that you're able to benefit from your errors. And this is not something that is routinely available to somebody with moderate to severe dementia. So they then are less able to learn from their mistakes. And so there is a framework of errorless learning where what you want is you want the person to minimize their errors when they're learning, relearning, or learning a task. So actually, a great example of this is more of a verbal example. So I think about if I go into a room in the hospital and I'm seeing a patient that I saw yesterday who has dementia, and I say, "Hey, Mr. Smith, I'm from physical therapy. Do you remember my name?" Which I would never ask somebody with dementia. I wouldn't ask them any kind of orienting question, but do you remember my name is probably the worst of the worst, right? And he goes, is it Gladys? No, it's not Gladys. I'm Julie. I'm your therapist, Julie, right? And then before I leave, I say to Mr. Smith, okay, I'm going now. How about my name? You remember my name? Guess what Mr. Smith is going to say my name is? Gladys. Because Gladys was internally generated, and that's going to be his default, right? So I think that's a really good example to kind of think
I
about
see.
errorless learning. If I just come in and go, hey, Mr. Smith, I'm Julie from physical therapy, then there's no room for error. And if I do, want him to learn my name, then I might give him hints at it as we're going, but I don't need him to learn my name. But to make this relevant to, let's say I have a patient with dementia who has now a fractured hip and they're going to use a walker and they've never used a walker before. So they don't have a motor program for using a walker. And so when we think about, okay, we got to push from the chair to stand and we got to then reach to the walker, right? So we have these components of it. Or I may say, oh, he's got to slide forward in the chair, push from the chair, reach to the walker, right? It could be even bigger. It could be he's responsible for locking the chair. But however many steps we have, then with errorless learning, we're right on top of them. We anticipate the errors. We don't let the mistake happen, right? So if he tries to get up from the deep in the well of the chair, we abort. We help him move forward before he tries to do it the wrong
Love
way.
that. Abort.
Abort,
And make it
right?
happen.
Yeah. And if he tries to stand up grabbing for the walker, no, we don't even move forward. We guide the hands back down. And so the framework is, if we have them practice the task the correct way in the correct sequence while learning, then that's what's going to stick. That's what's going to be the default. Whereas if he's trying to get up from the well of the chair and he's reaching for the walker to get up, doing it incorrectly repeatedly, then the likelihood of him picking up the correct mechanism is really shot. So the downside of this is you got to be a hawk. Like, you have to be watching, and not just you, but your whole team. So the nursing staff, the family, all of the therapists on the team, everybody's got to be on the same page, and we have to be diligent those first few days of practice. And that's hard. That's hard.
It is. And anticipating. So you're watching and anticipate, you know what's going to happen next. Just make sure you abort. I
Yeah.
like that.
Yeah.
Abort now.
And we're good at that, right? We observe like no other, right? All the, OTs, PTs, we are great observers, right? And so it's really not that hard to anticipate it. When you start to see, somebody's hands open up like they're going to reach forward and grab the walker, then you know where he's going, right? So really thinking about that. And it's getting the whole team on the same page that can be really difficult with that. So I think if it were easier to put into play, we'd see how successful it was. But it's a hard one to put into play.
This is just a good reinforcement. We know salient and functional goals, like you said, but recognizing that with our other patients, allowing them to error helps them learn, where here we want to focus on errorless learning and more blocked practice with, again, repetition overall, but constant. And so I think, setting your framework up like that, and then, making the environment. So all those pieces I can see now, from environmental awareness to communication, going in and so always starting with putting their warm, fuzzy sweater on
Yeah.
every single time, so that, the familiarity. So I can see, I just really love how you did these 4 aspects, and how they all kind of flow together.
Yeah. Thanks.
Yeah, I love it.
And I think, the last piece, and this is so true of any geriatric practicing, or any geriatric physical therapy or occupational therapy session, really reminding ourselves that we should be in tune to the level of challenge and to the intensity with which we are asking our patients to function, right? And that's become so big in our literature lately, just this idea of working hard is not contraindicated. It doesn't matter how old you are. So that idea of really pushing our patients to their safe limit. And I think, one of the things I kind of pride myself on in the training that we've done, in the small studies we've done for balance training, is that we don't offer rest breaks. We're for 45 minutes, and we do not offer a rest break. We watch our people carefully, and if somebody looks like they need a break, we offer it to them individually, but we never offer the group a rest break, because guess what? They're going to take it, right?
Yes,
If you say, do you want to sit down?
absolutely.
They're all going to want to sit down. Now, everybody says yes. So really pushing that level of challenge. Somebody who has, this is true of all older adults. So when somebody has dementia, don't forget that. Don't forget that challenge and that level of intensity is just as important.
I love that. So glad you brought that up, because I think, yes, more intensive. So there's so many great specifics in that. And just to reinforce, when you talk about certain patients or conditions, really you're saying this is effective for all different levels, right, from function.
I think it
Yeah.
is like it's a general framework, and when I think there are things within this framework that'll help me with my patients who have very mild dementia. Sometimes somebody with very mild dementia, um, really, you don't have to modify things too much from how you would work with somebody who has no dementia, right? But there are things with mild dementia that you may find some nuggets of things in here that would be helpful. And even somebody, as somebody progresses through to more of a moderate dementia, I think a lot of these communication and relationship building things become probably much more important. Um, and the motor learning component, I think, the thing I try to be careful of is not to always default to the lowest common denominator. Like, I don't want to treat everybody like all they can do is answer yes, no questions. I don't want to assume the lowest level of functioning for everybody with dementia. But I want to be prepared to uh, to modify how I'm interacting with somebody, so that if I do, and like I said, I'm pretty observant. So if I see a sign of confusion as I'm interacting with somebody, then I can change gears and I can decide, okay, I think I've lost them, and let me try a different strategy to really see if I can get them motivated to come with me, right? So that what we're trying to do is really help somebody self-actualize a little bit, right? So it's not all about we know that this idea of self-efficacy and self-actualization is so important throughout the lifespan. And again, dementia doesn't negate that. And so if I can create this relationship, create this rapport, and help somebody make a decision, yes, I do want to walk with you, yes, I am going to work on this activity, that's actually huge, I think, for their emotional well-being, as well as, from a PT perspective, working on their mobility, from an OT perspective, working on their ADL self-care skills, leisure activities, whatever it is. So really trying to create this relationship, use the communication strategies and the environmental strategies and our expertise on motor learning to kind of meet the patient where they're at in terms of their cognitive capabilities. So I feel like the framework has tidbits that could be helpful for really mild dementia. And we actually know from the literature that even people with pretty severe dementia are capable of relationship. And so we I think some people don't believe that, but if we buy into that and there's some evidence to support it, then we don't give up. And so we really try to capitalize on what might work with this patient who's in front of me right now.
Nice. So yeah, just you need more options. If it's not working, so don't assume, but try. And then if that doesn't work, have your other options and just utilize your observations.
Yeah.
Is that
Yeah.
accurate? Okay. So all right. Well, we've covered a lot, and I was just looking at our time here, so I'm trying to figure out what I want to know. When we look at the clinicians, keep in mind when considering the perspectives of others, like what should they be thinking of when you're just? I mean, and you said a lot of this, but specifically like the patients' families, the other care
Yeah.
providers, like are the word choices, any kind of strategies like that, talking points to buy in and carry over, but from the family.
Yeah, I think I'm actually going to take this opportunity to talk about one other thing that I haven't really talked about yet. And that's this idea of excess disability that we see in this older adult population when individuals have dementia. And so, excess disability is exactly what it sounds like. It's when people who have dementia appear functionally more disabled than they should, based on uh, their physical capabilities. And so I feel like this is like low hanging fruit for us to help somebody with dementia improve their functionality. Probably the majority of excess disability we see, or the main reason why people seem more disabled than they should be, is because people do things for them all day,
Yeah.
right?
I get
And so a lot of this just has to do with good education. Sometimes it's just you're just in a hurry. You got to move, and you have to get if your mother has dementia and you're trying to get to the physician's office, you're like, okay, mom, let's go. I'll put your dishes in the dishwasher. We got to get out the door. Let me help you with your shoes. Here we go. I've got your car door. Let me buckle you in. We got to go. Right. So sometimes you just have to help because you just don't have the time not to. But sometimes you don't. And so if you buckle somebody into the car and open the car door for them and buckle them in every time you get in the car, they're going to lose the ability to do it. And they'll get tangled up in the seatbelt and they won't be able to figure it out on their own. But if you buckle them into the car, open the door for them when you're in a hurry, but when you're not, when you have a couple extra minutes, when you're going to the grocery store or you're going to pick somebody up, and you let her figure it out with some guidance if she needs it, then that's going to help to maintain that motor skill over time. And so it can be something as simple as that. It could be, literally taking the dishes from the table to the dishwasher. A person, I did a lot of home care in my day, and, I would find myself talking to families about, whoa, 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 stop doing so much. And so when you constantly clear the table, rather than just let the person carry their dishes to the counter or put them in the dishwasher, rinse them and put them in the dishwasher, like these types of skills are lost when they're not practiced. And so I feel as though this needs to be like a public service announcement, general education for families. But I feel as though if we pull back in the assistance giving, if care partners and families pull back a little bit and allow a little time for people to maintain the skills that they have, then that would really help in the long run to maintain that independence, right? Because if I don't do anything for myself over a period of time, then I lose the ability to do for myself. So I kind of
so.
hijacked that question, but this idea of excess disability and trying to avoid that from happening or trying to reverse it if you see it is all about care partner education.
I love that. And I'm so glad that you had a chance to highlight that piece because it's important. But we only have a minute left. So if you had to narrow it down, what are the top 3 action steps clinicians should take to make the biggest difference? Just to summarize what we talked about.
Smile. Just smile. Read the room and be flexible. Don't go in with a preconceived notion of everything you're going to get done. Be flexible. And if your patient isn't giving you what you want, look internally. Is it me? Ask, is it me? Because the answer is yes, it's you. Think about something you could be doing differently that might get a better result from the patient you're trying to work with.
That's just amazing advice, really, for so much of the population we work with in general. But I just love that summary. And oh my gosh, Julie, thanks so much for joining us today and offering such meaningful guidance on dementia care. Your focus on just being thoughtful and practical strategies and challenging your assumptions, I don't know, it gives us all something to take back to the clinic. So I really appreciate you taking the time to share your expertise with us.
Thank you so much for having me. I really enjoyed it.
Have a great day.
You too.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.